So, what happens when the heart is failing and medications just aren't cutting it anymore? Well, we have to bring in the heavy machinery. We're talking about short term mechanical circulatory support. And look, if you're training in cardiology, critical care, or cardiac surgery, mastering these devices is absolutely essential. So, today, that's exactly what we're going to do break them down in this handy guide. This is it. This is the question we face at the bedside, right? You've got a patient in cardiogenic shock, their heart can't squeeze effectively, the inotropes aren't working. What's your next move? The answer, more often than not, lies in mechanical circulatory support, or MCS. So, what is short term MCS at its core? Really, it's all about buying time. These are incredible devices that we can deploy pretty quickly to just take over the job of a failing ventricle. They get blood flowing again to the body's vital organs, which gives the heart a much-needed break, a chance to rest and maybe recover. Or it acts as a bridge to get us to a more definitive solution, like a heart transplant or a long-term device. Okay, here's our game plan. First, we're going to talk about the universal goals of any support device. Then, we'll start with our baseline, the IABB, and kind of build up from there to the more powerful percutaneous VADs. After that, we'll hit the ultimate backup, ECMO, before we put it all together to figure out how we choose the right device and where this whole field is heading. So, before we get into the nitty-gritty of the hardware, let's just zoom out for a second. What are we fundamentally trying to achieve here from a physiological standpoint, no matter which device we end up picking? These are the big four. These are the core benefits we're chasing with any MCS device. Number one, you've got to get blood flowing to the end organs, the brain, the kidneys, you name it. At the same time, we need to relieve that dangerous backup of pressure in the heart and lungs. That means lowering the heart's workload, reducing what we call wall stress. And finally, we want to boost the heart's own blood supply by improving coronary perfusion. All right, with those goals in mind, let's get into the actual devices. And we're going to start with the one you'll probably see most often, the intra-aortic balloon pump, or IABP. This thing is our historical workhorse, and it's the perfect baseline for comparison. The IABP has been around forever, and for good reason. It's familiar, it's super fast to put in, and it's relatively cheap. But, and this is the crucial part, it's just not that powerful. It gives you a modest hemodynamic boost at best. And maybe most importantly, when you look at the big clinical trials, it has never been shown to actually save more lives in cardiogenic shock. And that very limitation, well, that's exactly what pushed us to innovate more powerful devices. And that brings us right to our next class of devices, percutaneous ventricular assist devices, or PVADs for short. These were developed for one reason, to provide the horsepower that the IABP was missing. So here you have it, the central trade-off in mechanical support. With PVADs, you get that powerful hemodynamic support that the IABP just can't deliver, but it absolutely comes at a cost, and that cost is a higher rate of some pretty serious complications. We're talking about bleeding, hemolysis, which is where red blood cells get destroyed, and limb ischemia, poor blood flow to the leg because of the big catheters we have to use. The two main players in this space are the Impella and the tandem heart. And as you can see, they work pretty differently. The Impella is what's called an axial flow pump. Seriously, just think of a tiny Archimedes screw that actively pulls blood from the left ventricle and shoots it into the aorta. The tandem heart, on the other hand, is an external centrifugal pump. Now, to get blood to it, we have to do a transeptal puncture, literally poking a tiny hole between the atria to pull blood from the left atrium. But the key takeaway for both, they directly unload the left ventricle, and that is a major, major advantage. And to really hammer home the risk we were just talking about, just look at this number. A huge registry study of patients in cardiogenic shock found that using a microaxial LVAD like the Impella was linked to a 15.4% absolute increase in bleeding complications compared to the good old IABP. That is not a small number, and it's something you have to factor into the equation when you're choosing a device. So, when do we actually pull out these more powerful, riskier devices? Well, they're really reserved for our sickest patients. This could be to support a really high-risk coronary intervention or to manage someone in profound cardiogenic shock after a heart attack. Sometimes we use it as a temporary bridge to a bridge while we figure out a long-term plan, or even to provide support during other tricky, high-risk procedures. Okay, but what if the problem isn't just the heart? What if the lungs are failing too? That's when we need to call in the ultimate backup, our most comprehensive form of support, ECMO. ECMO stands for extracorporeal membrane oxygenation. And the key thing you have to remember about ECMO is that it does two jobs at once.
It's a pump, so it supports your circulation, and it's an artificial lung that oxygenates the blood and gets rid of carbon dioxide. It really does provide full cardiopulmonary support. Now, it's absolutely critical to know the two main flavors of ECMO. You've got veno-arterial, or VA ECMO. Here, we pull deoxygenated blood from a vein and return oxygenated blood back into an artery, completely bypassing the heart and lungs. This gives you both cardiac and respiratory support. Then there's veno-venous, or VV ECMO. Here, the blood goes back into a vein, so it still has to get pumped by the patient's own heart. That means it only provides respiratory support. So, for our purposes for cardiogenic shock, we are always talking about VA ECMO. But VA ECMO creates this very unique problem. By pumping all that blood directly back into the arterial system, it massively increases the pressure that the poor, failing left ventricle has to pump against. We call this increasing the afterload. It can get so bad that the aortic valve can't even open, blood backs up into the lungs, and the pulmonary edema actually gets worse. Not good.
So how do we fix this? How do we solve this afterload problem? Well, the really elegant solution is to combine our therapies. We can add an Impella pump into the mix, along with a VA ECMO circuit, a strategy that's been nicknamed ECpella, and that Impella can directly pull blood from that stressed-out left ventricle and decompress the whole system. This lets the heart finally rest while the ECMO takes care of the rest of the body. Pretty clever, right? Okay, we've walked through all the individual devices. Now it's time to zoom back out and put it all together. Let's talk about how these choices actually play out in the real world. This summary table right here, this is your money slide. This is the high-yield takeaway. As you move from left to right, from the IABP to the PVADs to VA ECMO, the level of support you get just skyrockets. But pay close attention to the trade-offs. The best LV unloading, that's from the PVADs. But VA ECMO actually increases the LV load unless you add another device. And only ECMO helps you with oxygenation. Of course, each one has its own signature complication profile. This is the mental framework you need to have when you're trying to choose the right device for the right patient. And you know, these devices are becoming more and more important every single day. Why? Because the heart transplant allocation policy here in the US now gives a very high priority status to patients who are sick enough to need one of these short-term devices. And that policy change is almost certainly driving up how often we use them as a bridge to transplant. But bridging with these devices comes with a pretty stark reality check. This quote, it comes from a large French registry, and it's sobering. It found that patients who were bridged to a heart transplant on ECMO had a 1-year survival of only about 52%. Compare that to over 75% for patients who didn't need that level of support. It just goes to show you how incredibly sick these patients are, and it highlights the immense challenge of getting them not just to a transplant, but safely through it. And all of this leaves us with the big question for the future, doesn't it? We have these unbelievably powerful tools that can literally pull patients back from the brink of death, but they carry really significant risks. Learning how to select the right patients, how to manage the complications, and just how to use these devices more wisely, that is the challenge that is going to define the future of cardiogenic shock management.